and begin. Thank you, everyone. My name is Eric Colchmiro, Director of Government Affairs for the Alzheimer's Association in Maryland. Today is our final Maryland Advocacy Week presentation. I want to say thank you first to all of our advocates for joining us today and for joining us for a series of events over the week, including elected official meetings at night. And we had more really moving meetings last night and small group conversations there, and then larger conversations like this one, like with Secretary Kramer earlier in the week, like with Stephan Ellis, the state's long-term care ombudsman. And we're thrilled today to be joined by Quincy Samus, who oversees as chair Maryland's Virginia I. Jones Alzheimer's Disease and Related Disorders State Council, and is going to talk about where things stand with the next state plan on Alzheimer's and other dementia. So before I go any further, I want to turn it over to our Greater Maryland Executive Director, David McShay, for some opening remarks.
Thank you so much, Eric, and thank you all for being here today. I have had the pleasure of serving on the Virginia Jones Council for about a year now, and it's just such an honor to work with so many people that are personally and professionally passionate about this cause. And I'm especially grateful to Quincy for chairing it. We also work with Quincy on a memory grant, so we're incredibly grateful for her partnership and for her passion for our cause. So I'm very excited for today to hear more about the plan and how it's coming to life in the months and years ahead. And so with that, I'm going to go ahead and turn it back over to Eric.
Thank you so much, David. There we go. Thank you so much, David. And just echo the gratitude for Quincy for her work in a volunteer role as chair of the council and just overseeing what is, I believe, an ambitious and fantastic guide for how we can improve the lives of individuals with dementia, their loved ones, and their caregivers as we move forward. So Quincy, I'll turn it over to you.
So thank you both for such a wonderful and warm welcome. I am, Eric, if it's possible, if I can share my screen.
There we go, just made you the co-host, so you should be able to do it.
All right, let's. So if you can stop sharing yours and then I'll, there you go, perfect. Okay, great. Very happy to be here. And also I wanted to acknowledge Anna Nelson, who's also on the council, along with David McShay. She's the representative from the National Capital Alzheimer's Association region. We all have worked over the past 2 years to really kind of develop this plan. And so I'm really happy to be able to walk you through it and provide some comments kind of on where we're hopefully headed for 2022, 2026. So just a little history of the, just a brief history of the council and the charge. In 2012, the ADRD Commission published Maryland's first ADRD plan. That was in 2012, and it documented issues related to Alzheimer's disease and related dementias in Maryland and made a set of recommendations to serve really as a blueprint for the state to address the needs of individuals with dementia, their families, and caregivers. In 2013, the Virginia I. Jones Council, which was named in honor of Mrs. Virginia I. Jones, who was a dedicated public servant in Maryland, who also lived with Alzheimer's disease for almost 2 decades. So the council was named after her and was authorized to continue the work of the commission. And it was charged with monitoring the state plan, reviewing and promoting and expanding statutes, policies, and programs to better serve Marylanders living with dementia and their families. In 2019, the council was, the authorization was extended again, and it was reseated, and the council was directed to update the 2012 Maryland State Plan. In addition to that, we are also charged with examining the needs of individuals with Alzheimer's disease and related disorders, as well as identify needs of caregivers to figure out basically how the state can assist most effectively. And then the third charge is really to advise the governor and General Assembly on policy, funding, and other issues related to Alzheimer's disease, as well as development and promotion of strategies that encourage brain health and reduce cognitive decline. So that's just a brief history of the council. In terms of the membership of the council, so there is a representative from the Senate, there's a representative from the House of Delegates, there's also a designee from the Department of Health and the Department of Aging. The Alzheimer's Association Greater Maryland chapter also has David serving, as well as Anna Nelson from the National Capital Area chapter. In addition to these seats, there are other members that are appointed by the governor. This includes 7 healthcare professionals with relevant professional experience, 3 human service professionals, 1 elder law attorney, 2 research professionals, 2 family caregivers, and then these seats can, at the recommendation of the council, be filled with other members who have relevant experience necessary to fulfill the duties of this council. The idea is really that the members should reflect the geographic, racial, and ethnic, cultural, and gender diversity of the state to the extent practical. And currently we have 2 fairly new vacancies that are on the council. If at the end, if anyone's interested in applying for the council, we can figure out how to get you a link to the appointments page. But these are open seats for an elder law attorney with applicable experience, as well as a healthcare professional. The next slide shows you the current members of the council. And so you may see people there who you recognize. And then I just want to provide just a little bit about the state plan and kind of this process that we've undertook to create the most comprehensive, forward-thinking, data-driven roadmap for Maryland that we could. So throughout 2020, 2021, the council undertook a collaborative process to update and enhance the 2012 plan. This included conducting an environmental scan of relevant national, state, and local initiatives that had policies or programs that were relevant to either Alzheimer's disease and related disorders or healthy brain aging. The council also worked on reviewing 18 plans from other states that had been recently updated. And we basically reviewed those and organized those state recommendations by our goals that we would like to do to ensure that if other states had great ideas, we would be able to review them and potentially incorporate them into our plan as well. We also conducted a series of open council work group meetings and public listening sessions and solicitation of public comment. The final plan, as Eric mentioned, was approved by the council in late October, and the plan is currently under review for clearance to publish publicly by the Maryland Department of Health and Maryland Department on Aging. And so that is where the plan is at the moment, and we're hoping that it will be published very soon. So just to give you a sneak peek of what the plan kind of looks like in terms of the sections. This is how the plan is broken up. You'll notice that we have a background section, and then the meat of the plan is really the goals that are put forward for 2022 to 2026. In terms of the overall goals of this plan, we have 5. The first is to expand efforts to support public awareness, prevention, and early detection of Alzheimer's disease and related dementias. Number 2, it's to really focus on enhancing the quality, access, and coordination of ADRD care for those who are currently living with dementia. The third goal is to enhance and expand supports for family caregivers. The fourth goal is to advance ADRD research and encourage the use of evidence-based practices. And then the fifth is to enhance our data capabilities related to dementia and dementia impact and the effects of intervention programs so that we're better able to understand how we are, where the needs are and how we're doing in terms of meeting needs for Marylanders. So just a little background, you guys, I'm sure, have heard this already in the Advocacy Week talks, but I'll just highlight a few things. So ADRDs are very common, and the prevalence in Maryland will substantially increase over the next several decades. In 2020, 110,000 Marylanders 65 and older were estimated to be living with Alzheimer's disease, and this is expected to increase, unfortunately, by 18% to 130,000 by 2025. We also know that dementia is strongly associated with high healthcare costs and long-term care costs, with high burden for individuals and family care partners. For example, Maryland Medicaid in 2020 spent $1.23 billion to care for people with dementia, and this is expected to increase by a quarter by 2025. We also have estimates that there in 2020 were approximately 238,000 family caregivers caring for people living with dementia in Maryland, and they contributed an estimated 364 million hours of unpaid care. And so if you put an economic value to that, that is approximately 6.6 billion. We also know that, unfortunately, some of the negative impacts of dementia caregiving can also result in things like work loss productivity. So taking sick time, family caregivers who need to take sick time, and also those who may actually have a premature retirement because of caregiving responsibilities. There is a lot of hope, however. So we also have learned from recent huge reviews of data, international data, as well as national data, that risk reduction and prevention of ADRD may be possible. So best available evidence suggests potential for reducing risk of ADRD is significant. So the epidemiological data suggests that if you address a set of modifiable risk factors over the course of life, we may be able to reduce ADRD risk by about 35%. We also know, from practice and from evidence-based literature that effective care and treatment options do exist. And so, however, many people living with dementia and their family caregivers have needs that go unevaluated and unmet. And we know that is often because of the lack of financing for some of the long-term services and supports that are needed, because many needs, as you guys know, in dementia are non-medical needs. Also, coordination of dementia care is inadequate, and there's the system of long-term care is fractured in many ways. Finally, as part of background, people belonging to minority groups, women and those living in poverty are disproportionately affected by ADRD and have significant more healthcare disparities and worse outcomes. So this is kind of the key points that we are using to ensure that going forward, we're trying to address these in an effective way. So the plan overall is guided by mission, vision, and some principles. So the mission of the council is to provide Marylanders and their leaders with an informed and proactive roadmap for ADRD that enhances key areas that are important to individuals, families, health systems, and networks, and that align with national level strategies, resources, and opportunities. The council envisions a dementia-capable Maryland that provides and values care and services through a whole person coordinated approach to meeting the needs of Marylanders and their caregivers across the disease spectrum, from time of symptoms to time of death. And the plan is guided by 5 underlying principles related to quality and the delivery of services. These are equitable care, evidence-based care, collaborative care, care that is both person and family centered, as well as taking a life course perspective to reducing risk of dementia and to reduce harm reduction once people have dementia. So just a few more notes about this plan. You're going to see that this plan is very hopeful, very expansive, very comprehensive. And it is really meant to support and enhance the infrastructure that we have currently in Maryland, to provide more robust public awareness and empowerment, to provide better and more coordinated care, a more dementia-capable workforce, comprehensive caregiver support, and care innovations through research. The implementation of this plan will require a long-term and phased multi-step approach. The successful implementation will include strategic engagement of a number of partners along the way. This is just the first step in realizing the goals. It is a process that will take a lot of stakeholder collaboration, additional resources, and dedicated oversight for making sure that the goals and actions are implemented successfully. The plan has suggested broad and flexible timeframes for the implementation of these recommendations, but these will be likely adjusted based on the availability of resources and other factors. One key component that we have put into the plan, and it's actually goal 1A1, is that there should be a responsible director level person who is charged with the oversight and coordination and implementation of this plan. So essentially, this plan needs a quarterback. It needs someone who is going to be able to provide oversight, coordinate, create timeframes and for specific action items, create milestones and measures of success. So that is a core feature of the plan and its success. So I am just briefly going to go over a few of the overarching strategies and recommendations that are included under each of the 5 goals. To give you an idea of what is included. So the first goal is related to public awareness, prevention, and early detection. So under that goal, we have 3 strategies, and then under each strategy, we have a number of recommendations and policies. So for example, the first is increased public awareness. So one of the policies recommended is to communicate the results of the behavioral risk factor surveillance system to partners and local government and community organizations to basically increase the publicity of the Maryland-specific cognitive health and caregiver data. In terms of the strategy for increasing early detection and diagnosis, one of the recommendations that's included, for example, is to educate healthcare professionals about and promote the use of the Medicare annual wellness visit, which, as you may know, includes a cognitive assessment and follow-up if there are cognitive impairment has been detected, which is currently not being utilized, but is covered under Medicare billing codes. The third strategy under this goal is to advance prevention strategies in healthy brain aging. And so this includes things like including brain health messaging in existing publicly funded health promotion and chronic disease management activities, and identifying high-risk populations so that we can specifically target these healthy brain messages to those for increased outreach efforts. So those are just a couple of examples, and I will move on to the goal 2. So for goal 2, we have 4 strategies. Number 1 is, and all of this is about quality and access and coordination of care for people living with dementia. So the first is to build a diverse and interdisciplinary dementia-capable workforce. And so we have 8 suggestions under that. This includes things like establishing a standardized ADRD training for healthcare professionals and all direct service workers. It also includes things like addressing current and projected workforce shortages, which we know have been highlighted and amplified by the COVID-19 pandemic. So the next strategy is increasing access to high quality home and community-based services in promoting coordination of care. So this could include increasing the availability of critical types of health-related long-term services and supports in the community, such as access to adult daycare centers, home health care, case management, personal care, medication review and management. Also increasing the availability of critical types of non-medical LTSS, which include services related to daily living, social support, and other types of supportive services like caregiver respite and nutritional services. Third, we have promoting innovations in financing in incentivizing high quality medical care, medical and long-term care services. So this includes eight actions or policies, and a few of them are, for example, reviewing current Medicaid eligibility requirements to determine how coverage could be expanded to cover more individuals with ADRD in need, including use of Medicaid home and community-based service resources. And then finally, for this goal, we have enhancing quality of care in nursing home, assisted living facilities, and other residential care facilities. This includes 8 policies as well. One includes establishing a consumer-facing information platform that provides users with a method for selecting assisted living services in Maryland and a method for comparing the quality of services across facilities. So those are some examples. I'm going to move on to goal 3. So goal 3 relates specifically to enhancing and expanding supports for family caregivers. And we have 5 strategies under goal 3. The first is to better understand the unmet needs for family caregivers through doing a comprehensive needs assessment and really focusing on diverse and underrepresented and under-resourced groups. And so that we can better understand their needs, their unmet service needs and supportive care needs. Our second strategy is assisting families in planning for ADRD care needs. This includes 9 policies or actions, such as increasing the use of the Maryland Access Point as a referral source for community resources and as a resource for people with dementia, through enhancing the curated content and listings that are provided within that platform. Number 3 is promoting and expanding family caregiver supports across various settings. This includes 12 different policies. Example of this is expanding the delivery and accessibility of free statewide ADRD capable caregiver workshops and trainings in the communities so that families are better equipped to deliver care at home through existing partnerships. The 4th strategy is addressing caregiver health and wellness. So this includes recommendations such as increasing availability and access to caregiver-focused wellness and support programs, these especially among underserved and under-resourced communities. And then finally, we have addressed COVID-19 pandemic and similar events. So we recognize the need that COVID-19 has hit persons with Alzheimer's disease and families hardest in terms of excesses in poor outcomes. And so we need to learn a little bit more about that and understand experiences and challenges, especially in long-term care facilities, so that we can better prepare and plan for the future. And then goal 4, and we're almost done. Guys, you're hanging in there. You're doing a great job. I know this is a little bit dry. So we have 2 more goals. Goal 4 is advancing ADRD research and encouraging evidence-based practices. So under this, we have 3 different strategies. The first is to identify and prioritize ADRD-related research need areas. So one of the things that we would like to do, or that we have recommended, is to convene a stakeholder group to plan and facilitate a biannual summit to identify specific high priority areas related to ADRD or ADRD prevention. Another recommendation under this is to explore the creation of an interstate ADRD research consortium to identify other states facing similar challenges and facilitate a collaborative partnership to leverage and share resources and funding between states to advance high priority research areas. A second strategy under this goal is to enhance funding and resource to support ADRD research and grow public-private research networks in Maryland. There are 6 policies under this. This includes such as working with key stakeholders to identify state funds and grant programs that could be accessed, applied for, or leveraged to address these key areas of ADRD research or service program evaluation needs. And then the third strategy is to enable and incentivize the translation of research to practice and use of evidence-based practices. So there's a set of policies under this, and one is to require use of evidence-based practices in new or revised regulation across all state licensed programs. So that is an example of that. And then finally, goal 5 is all about data capability and data infrastructure related to dementia impact and the effects of interventions. So the first is the first strategy under this goal is collection, analysis, and use of population-based surveillance data. So these include continuing what we call the BRFIS, which is the Behavioral Risk Factor Surveillance System, to understand cognitive health and caregiver data points at least every 2 years. Another action under this is to utilize the regional health information exchange in Maryland to characterize and track and evaluate the health characteristics of Marylanders with an ADRD diagnosis, and then link to their health utilization. So for example, how much of an increased risk are they compared to other Marylanders for having more emergency department visits, hospitalizations, home health utilization, et cetera. And a major part of this is to create a publicly available report on this data so that we can educate citizens on the impact. And then number 2 strategy under this is to support development and implementation of dementia-related outcome-based performance measures. So first of all, one action under this is to develop, using a stakeholder panel, develop and endorse a set of dementia-specific metrics for the individual with dementia and their care partner to drive improvements in care practice. And then working with state partners, promote the inclusion and tracking of these metrics within programs such as the Maryland Medicaid Waiver Program, local AAAs, the Maryland Access Point, and within the Maryland Total Cost of Care program. And then the third strategy under this goal is to promote the sharing and linking of population-based surveillance and evaluation data sources. So this really relates to expanding funding and support of public-private partnerships and the development of secure data repositories that enable an efficient platform for ADRD data management, analysis, and sharing. So this is really data analysis infrastructure so we can promote a better understanding how health programs are working, and then that will lead to informing policy and planning. So in terms of next steps, so this is the 2022-2026 plan. As I mentioned, it is currently under review, and we're hoping that the release will be forthcoming in a matter of weeks. We are planning press releases for when that becomes public. The council is also undertaking strategic planning to determine a strategy for advocating for the plan. We have another quarterly meeting, I believe on April 27th, which is an open meeting for the public. We have invited 2 representatives who are leaders in advocacy efforts for ADRD, one who is from California and one who is from Virginia, to come and talk to the council about their experiences with implementing and advocating for their state plans. And then we also welcome people to come from Maryland to come to our council and provide us with some education about Maryland-based initiatives, partnerships, programs, opportunities that may be coming up so that we can be better aware and potentially help in any way that we can as a council. So I will stop there. I will let you know that this is the website. If you search Virginia I. Jones Council on the Maryland Department of Health page, this is where you will be taken, and you can learn more about the council and about us. But I'll stop there.
Great. Thank you so much, Quincy. As mentioned at the start of this presentation and in the chat box throughout, if individuals have questions, please feel free to put them in the chat box. If you'd like them to be read anonymously, you can put them in the Q&A, or if you would like to say your question verbally, you're welcome to indicate that, and advocates can be unmuted. So going into the chat box to see what is first here. Thank you for the kind words from advocates. All right, we have a question or a comment from Michael who would like to speak verbally when there is time. So Michael, hold on one second. I'm going to unmute you and hopefully you should be able to talk. So just click the unmute button, Michael, in the lower left, and welcome your question or your comment for Quincy.
Good morning, Quincy, and thank you so much for this. I'm really excited to hear that you're part of the chair. I actually served on the Pennsylvania Planning Committee. I was actually appointed there by the governor also, and I was actually recommended by Harry Chan to be on that committee. I don't know if I heard you or misheard you. Did you not say that there's somebody with dementia on this committee?
So there is not currently a slotted seat for someone living with dementia on this committee, but it's actually something that we've been discussing as a council in terms of figuring out how we can have the legislation changed to require that.
Well, I'd love to play a role in that because I think that is totally unacceptable for them to have something that is going to impact people with dementia and not include at least one person. In fact, I usually believe they should have 2 or 3, but as you know, that's not so easy on these councils. But at the very least, they have to have one, and I'd be willing, if you don't already have somebody to be on that, I'd love to be a part of that and play a role. Like I said, I was a part of the PA and we finished that off. So feel free to reach out to me.
Michael, I completely, as an individual, I'll say I completely agree, and we will definitely reach out. In fact, at the last council meeting that we had, this issue was discussed, and so we are working on determining a way that we can make sure that happens. That is, I think, the wish of the council as well.
Well, I am very good at getting things done. Let me know who I need to talk to, and I guarantee I will make that happen. When NAPA came out, they didn't have anybody on NAPA, believe it or not, with Alzheimer's. I made sure that happened. So I can assure you I can make this happen.
Michael, thank you so much for your comment. I'm going to click the mute button, but if you have other questions or comments as we go through, please feel free to chime in the chat box and welcome your further comments. So I want to move forward to the next question in the chat box. Hold on one second. And excitement for the encouragement of interdisciplinary teams. Question from Gary Quincy. Can you speak in a little more detail with regard to the caregiver needs assessment and how it's developed?
Yes, thank you so much, Gary, for that comment. And I don't have the exact language of the recommendation in front of me, but we didn't go as far as to prescribe the exact methods and assessment items that would be included in the caregiver assessment. We recommended it as something that was needed, and we recognize that it will likely be falling under the quarterback's purview in terms of developing those methods and assessments. But if you have ideas of what absolutely should be included in that assessment, we would love to hear them.
Great. Thank you for the question, Gary. Next comment from Sue. Quincy, huge kudos to you and all the members of the council, and not who Quincy listed wonderfully at the beginning of her presentation, for such a thorough and comprehensive state plan. Looking forward to help advocate for it. And I just want to give Quincy a shout out on that front of advocacy. Quincy is an academic and a researcher by trade, but Quincy, taken to the mission of the council, was involved in our advocacy for putting a dementia point person in state government. And I'm really just thrilled and grateful to Quincy and other members of the council like Halima Amjad, Claudia Thorne, all of whom testified in person, submitted testimony. Grateful to our bill sponsors, Senator Augustine and Speaker Pro Tem Sample Hughes, that we have moving forward legislation which would establish a director of dementia services and brain health reporting to the Secretary of Health. It's an enormous accomplishment as this plan is getting rolled out to have that point person coming into place. So thank you for the comments, Sue, about advocacy right on amidst Advocacy Week. And I'm grateful to Quincy and all the members of the council who stepped up, and all of our advocates, of course, who stepped up. Next comment from Gary. Great job, Quincy. A lot of good information. Next comment from Lucia. Thank you so much. Quincy, I would like to know a little bit more about how the needs of family caregivers and other caregivers were determined, presumably when developing the state plan recommendations.
Yeah, so that, the data is one of the focuses or foci of the plan in terms of enhancing our abilities to better understand what the needs are, over the years, as well as needs in various regions, which may not typically be included or are under-resourced or, geographically different. And so in the plan, the data related to needs was very sparse from kind of a state-based level. So we included some data from some of the studies that have happened at Johns Hopkins University over the past several years. So these include NIH-based studies that included home visits where a team goes to the home and basically does an assessment to identify dementia-related needs for persons living with dementia and caregivers. And so some of those needs areas included needs for education about dementia generally. So what to expect, what does a dementia diagnosis mean, what are the symptoms, a needs assessment of how their knowledge was of different resources and community-based supports that they might be able to access to get their needs met. Also related to caregiver, their own medical, mental health and well-being. So we know that many times caregivers often don't engage in self-care as much as they should when they have intense caregiving responsibilities. We also looked at caregivers skills training and things like that. So, overall, if you look at the data that is coming out in the, it's published data and it's included in the report, many caregivers have unmet needs based on the data that we have. So we need more data. That's just kind of a little sneak peek. We need a better way to engage and incorporate the views and perspectives of people who are living in other parts of the state that study didn't include. So I don't know if that answers your question. I hope it does. We need more data. We need it collected in a standard way. And we need it on people who typically are underrepresented.
And Quincy, if you wouldn't mind, just a quick follow-up to that. There was a group who developed some of the caregiver recommendations. If folks wanted to follow up with you or the other members of the council, who was on the kind of the caregiver team?
Yeah, so I don't actually have that, in hand. So was that group 3? Probably. So I'd have to, if they email me separately, I can definitely let them.
Super. Next question is for Elise, from Elise. Thank you for the thorough report and strategy. As I am a Maryland resident working with a California-based company focused on early detection and monitoring of Alzheimer's disease, I'm curious what in a nutshell California has done and what we want to bring to Maryland. Also, how can people in digital health help you think about or use innovative metrics?
Yeah, so thank you so much, Elise, for that great question. So we are going to be hearing from Deborah Cherry, who is with LA Alzheimer's in California, who was very involved in California's ADRD advocacy efforts over the years. She's also an advisory member of the National Alzheimer's Project Plan group. And so we're going to learn from her on 4/27 about her experiences and any lessons learned that she thinks we could benefit from. I think as an individual, I'm just going to say, I think California is ahead of us when it comes to kind of building and planning the dementia public health infrastructure. And so we would welcome you to attend that April 27th meeting, and that meeting will be posted on the Virginia I. Jones Council website. So please do come to that, and we'll all learn together about what California has done that we might learn from. In terms of digital health, we actually do have that specifically called out, and I think at least one recommendation in the plan, and that is I think that is in goal 2, which is enhancing services and using digital health and telehealth and telemedicine to bring resources and knowledge and training and skills to under-resourced areas, for example. So that is one way that has been incorporated to the plan. But you're saying think about use of innovative metrics. So maybe that's not answering your question, but maybe you could further specify what you mean by that.
I think that's a really thorough answer, and we'll put, if it's all right, your contact information in the chat box, and maybe you and Elise can follow up offline on that one. I want to keep pushing us forward, though, because we have a number of other questions and comments. People love hearing from you again this year, Quincy, so thank you again for taking the time out of your really busy schedule. Next comment is from Gary. He says, thank you for your remark. I would love to get involved in helping with developing a needs assessment. My mother-in-law is totally confused, helpless, and bewildered as my father-in-law was recently diagnosed with the early stages of dementia. And Gary, I'm going to step in for Quincy here and just say, thank you for sharing that. Part of what we do here in advocacy and legislative affairs is sharing your story, and people who share their stories, whether it's individuals living with the disease like Michael and his passion, or moments like this, it brings it home for all of us as to why we're in this work, and is just such an important reminder of why we advocate and why we work together slowly but surely on solutions that may not be perfect, but are solutions that advance things. And just grateful for sharing there, Gary, and certainly important to follow up. Next question from Irma. Irma, thank you so much for the question, and good to have you on again. Hi, Quincy. Is there legislation out there for hospitals to better train hospital doctors and nurses and personal nurses on treating people with Alzheimer's? My experience in this area is that it needs improvement. Thank you.
Yeah, Irma, that is absolutely, unfortunately, the experience of many people who, the worst place for a person living with dementia or memory problems to be is in the hospital or in the ED. So in terms of our plan, specifically, we did not suggest legislation per se, but we have recommendations that relate to workforce capacity, standardization of training of all types of workforce members, including those working in hospitals as discharge planners, as staff who are working, for example, at the Maryland Access Point. We do specifically call out the need for training for different types of workforce, and you're right on with your concern that it does need improvement.
Muted. There we go. Unmute. Next comment. Quincy, thank you so much for your remarks. Your answers to my questions sound great. That one from Lucia. Next comment from Gary. Can you provide your contact information again if you're comfortable?
Yes, absolutely. I'm going to put it in the chat. And, what this makes me think also is, one of the things that we might do, Eric and maybe David, we could all kind of work together to make this happen, is to have, is the plan for some of our quarterly public, open public meetings for the council to have a panel of caregivers and persons living with dementia, so that we can hear from them on their experiences and what needs should be absolutely assessed and addressed, so we could have we could talk about that a little bit more, but this is making me feel like that would be a great use of our time.
Great thought. Next comment from Elise, super info. Thanks. Quincy puts her email in the chat box. Thank you, Quincy, from Irma. David says, great idea, Quincy. Fully support that. And I will just add, we've talked about caregiving a bunch during this week, as one of our Alzheimer's Association Advocacy Week priorities is HB 731, talking about dementia caregiving. And one of the conversations I had this week was from a Carroll County caregiver who has been caring for her mom and has spent close to $1 million caring for her mom with dementia. And it just, that conversations like this one and throughout the week have kind of brought it home for me. I'm going to chime in. We have just a few more minutes left. And thank you again to Quincy for joining. I'm going to chime in with, as we have a break in audience questions and advocate questions, I'm going to chime in with one question of my own, Quincy, for you. You've laid out, and the council's draft plan lays out so many important priorities. And you've mentioned throughout the presentation resources. Can you refocus us perhaps and mention specifically from the slides that you addressed a few of the key areas where ongoing resources would be really important?
Well, so that's like a wonderful question. And so, as I mentioned in kind of the context, it is a completely comprehensive plan. This is not a plan that will be accomplished in 4 years. This is a plan that it takes a longer term view, but it attempts to incorporate all of the necessary pieces that would move us towards, in 10 years and 20 years, a healthier, hopefully risk reduction, kind of Maryland, where we see fewer cases because we have invested in both the healthy brain aging part of it, as well as the service part of it for people who are living with dementia. So that I'll couch it with that, like that it's absolutely comprehensive. Now, in terms of the approach to kind of tackling it, we as a council decided to be broad in terms of what recommendations we were prioritizing. And so absolutely getting the director level position to oversee and to plan for the implementation of these recommendations and to prioritize them and to come up with milestones and metrics to be able to report out what is the progress of achieving these goals and the recommendations. Like, that is, from my perspective, the number one thing that will need to be in place early on. Now, in terms of the other sections, I think that there's, in each goal, there are a few policies or recommendations that have already gotten underway, in that they're kind of like low-hanging fruit where we can enhance them. In some cases, there's already being things that are done to enhance it. Like, for example, the Maryland Access Point received a huge enhancement not too long ago, and that's an example. But there's a number of important funding opportunities that are availing themselves at this historic moment that could be used with a director who's kind of like coordinating kind of the public-private partnership. So for example, there's grants and funding for infrastructure building and for the evaluation of programs and services that's available through federal agencies such as NIH. So NIA has a huge amount, as you know, of allocated money for Alzheimer's disease and related dementias. PCORI, which is Patient-Centered Outcomes Research Institute. I hope I got that right. I don't know if I did, but they also have a number of grant opportunities for infrastructure building. The CDC has the Healthy Initiative and the BOLD Act, which authorizes funding for states to build infrastructure. And then there's, of course, there's always private groups such as the Alzheimer's Association and foundations that are focused on improving dementia care. So essentially, by organizing ourselves at this moment, we could stand to really leverage these very historic high levels of funding that have been dedicated to help regions and states improve their infrastructure. And so our job is to take advantage of those in this, over the next couple of years so that we can really, as other states have done, we can really, leverage those resources and make some headway. So I'll stop there. I hope that answers your question.
My goodness, that was fantastic. And as someone who worked in quality measurement at an earlier stage in his career, I appreciate any good health policy conversation that touches on PCORI. And you got the acronym right. I Googled it while we were gone. So thank you, Quincy. Thank you so much for being here. Thank you to our advocates for the questions. And before we go, we are going to do for our advocates, as promised at the start of the call for the first 5 people, our little doorbuster. Thank you for folks who have been here online. So appreciate everyone being here. We have 4 names. We will actually, since we took a break from this from last week, from yesterday, pull out 2 names to receive Alzheimer's Association fleece blankets as a little thank you for being here early. First name, Annette. Thank you, Annette, for being here. Next name, Michael Ellenbogen. Thank you, Annette. Thank you, Michael. Thank you, all of our advocates. Thank you to staff who have been here. Thank you again, especially to Quincy for taking the time out of her schedule to answer questions for the last hour and continuing to partner with the chapter across pillars and just doing such a phenomenal job overseeing the council in what is a volunteer role, but one that is just so important for Maryland's future, for the 110,000 Marylanders with Alzheimer's and dementia, their loved ones, their caregivers. Thank you so much, Quincy, and thanks to all of you. Have a great weekend, and just really appreciate everyone's ongoing participation in this, the last event of our Maryland Advocacy Week. Have a great day. Bye-bye.